With your permission, sir, can I start?
Yeah, sure.
Thank you, sir. Good evening, everyone. A very warm and hearty welcome to this JMitra webinar titled Enteric Fever Diagnosis, Challenges and Future Directions. We are very pleased to have with us today Dr. Ashok Rattan, who will be delivering this lecture. And now Dr. Ashok Rattan is a name that needs no introduction. Yet, for the purposes of this webinar, I shall give a small introduction. Dr. Rattan describes himself as an evidence-based scientist with malice towards none. And he comes to us with over four decades of experience in the medical fraternity. He has handled several roles and responsibilities in India, in Sharjah, and been at the forefront of medical education over the last 4 decades. He has worked, an alumnus of the Darbhanga Medical College. He's also been, he's done his MD, I believe, from the All India Institute of Medical Sciences, and thereafter been associated with several organizations, including Medanta, the Medicity Hospital, Arabian Healthcare in Sharjah, MGM Hospital in Jaipur, and Pathkind Labs, where he is currently working full-time as a mentor and advisor. Dr. Rattan, very pleased to have you with us today, sir. And without further ado, I would hand over the forum to you. All yours, sir.
Thank you. Let me load up my slides. Can you see my slides?
Yes, sir.
So good afternoon, everybody. Today we'll talk about enteric fever diagnosis, current challenges, and future directions. Enteric fever is also known as typhoid or paratyphoid fever, and it's a common bacterial infection and a major public health problem because it leads to high morbidity and mortality if not diagnosed and adequately treated quickly. World Health Organization estimates up to 21 million infections occur every year and leading to 161,000 deaths every year. Many people feel that it's a gross underestimation and actual burden is not known since enteric fever is not a notifiable disease. When you look at the world, then you'll find that it is the developing countries which seem to have the greatest burden. In countries like North America, the incidence is less than 0.1 per 100,000 people a year, while in South Asia is 976 per 100,000 population. In India, it's been guesstimated that about 6 million cases occur every year. It seems to be 140 episodes per 100,000 population in Calcutta and 273 episodes per 100,000 in Delhi. The incidence in children seems to vary depending upon its age, being maximum between 5 to 15 years. Peak time is in monsoon season between July and October because it's a waterborne disease. This is transmitted through contaminated water and food. Humans are the only source of typhoidal salmonella, and the infection spreads from the intestine of one person to the mouths of the susceptible host. It could be spread through flies. Of course, at this time, infection is mostly in South Asia. But there was a time in New York when there was one lady identified as Mary Mellon, who was a chronic carrier and she spread the infection to hundreds of people in New York. And she came to be known as Typhoid Mary. Once she was identified, she was quarantined and she was imprisoned for many, many years. So much so that a novel as well as a movie was made on her story as Fever. Salmonella are a group of gram-negative motile bacteria. Clinically, infection can be can be grouped into two. One is enteric fever caused by typhoidal serovars that can lead to chronic infection of fatality. And the second one is non-typhoidal salmonella, NTS serovars, which usually cause self-limiting gastroenteritis. Enteric fever needs to be quickly diagnosed and appropriate antibiotic therapy need to be instituted as soon as possible, or it will lead to chronic infection or end fatally. Contact tracing may be required in certain situations. For infections with non-typhoidal salmonella, specific therapy is not indicated in immunocompetent host, but outbreak investigations may be required to identify the source. Non-typhoidal salmonella will normally cause self-limiting gastroenteritis. And if you give antibiotics for this gastroenteritis, then the excretion of salmonella gets prolonged. So it is important to diagnose it correctly, but no antibiotic treatment is required. In the recent few weeks, there has been a recent outbreak in US, which CDC has traced to contaminated onions. Watch the report.
A multi-state salmonella outbreak is linked to onions imported from Mexico. According to the CDC, the produce sickened more than 650 people in 37 states. Right now, no deaths are reported, but nearly 130 people went to the hospital. According to the CDC, the outbreak is linked to red, yellow, and white onions distributed by ProSource Inc. and imported from Chihuahua, Mexico. Investigators are still working to see if the outbreak is linked to other onions or suppliers. Katie Johnston for CBSN, Los Angeles.
Salmonella could be grouped, as I suggested, into two basic groups: typhoidal salmonella and non-typhoidal salmonella. That means then you're grouping them into the pathological features. But Kaufman and White initially did the serotyping scheme in 1934, which classified all salmonella on the basis of their lipopolysaccharide antigens, and he found that there were two types of antigen. One was O antigen, which meant which is because of LPS, lipopolysaccharide, and the H antigen was because of flagella, as you see on the right slide. Why somatic antigen will be known as O and why flagellar antigen will be known as H is because Kaufman was a German, and he found that when salmonella grows, if it is motile and it has flagella, then it will create a mist kind of growth. While mist will be Hauch is German for mists. While if the flagella were missing, then it will be ohne Hauch. That means without mist, and the O from ohne is taken as the O antigen, which is the lipopolysaccharide antigen. And Hauch is breath, which is taken for the H antigen, which is the flagellar antigen. Based on this, he then made antisera, and after a number of absorptions, he could identify that Salmonella typhi has the O antigen is 9 antigen and the flagellar antigen is D. In some cases of Salmonella typhi, there would be a capsular antigen known as VI antigen, which will mask the lipopolysaccharide antigen, and this is heat labile. So if you put it in boiling water, then VI antigen will be destroyed. VI antigen was also present in Salmonella paratyphi C, Salmonella Dublin, and Citrobacter farinae. As you notice here, that there is cross reaction between the O antigens of various Salmonella. So Salmonella can be grouped based on DNA-DNA hybridization, followed by multi-locus electrophoresis or multi-locus sequencing into two broad groups. One is Salmonella bongore, which is not pathogenic to human beings, and Salmonella enterica. Salmonella enterica is then further divided into 6 subgroups, and it is subspecies enterica, to which you have typhoidal and non-typhoidal Salmonella. Typhoidal Salmonella cause systemic infection. If it is typical systemic infection, then it is typhoid, and if it is slightly milder, it is paratyphoid. While if it is normally gastrointestinal, it is caused by non-typhoidal Salmonella, which are pathogens for animals but accidentally infect human beings. Now, since there appear to be two pathovars, one is typhoidal Salmonella and the other is non-typhoidal Salmonella, so the pathogenesis of these two would be different. Let us first take the easier one first, that is non-typhoidal Salmonella. Once they are actually, once they're taken into the stomach, is in the food or with water or food, once they've been ingested, then they are absorbed from distal ileum and colon. They are engulfed by the macrophages, which recognize the pathogen-associated molecular patterns, PAMPs, which are present on non-typhoidal Salmonella, especially the LPS and flagella. This will then, once the macrophages has engulfed the non-typhoidal Salmonella after recognizing their PAMs, this will attract T lymphocytes as well as neutrophils, and it will lead to production of IL-8. This will cause inflammation and then suppression of infection. So there would be only diarrhea, and the bacteria will be destroyed in the lumen, and so no other consequence will occur. On the other hand, when typhoidal Salmonella are absorbed, then they would be they are absorbed from distal ileum, and they have a predilection to they have fimbria, which has special affinity for epithelium over the cluster of lymphoid tissue known in the ileum, known as Pear's patch. So S. typhi, through their fimbria, will bind to the epithelium over Pear's patch. This bacteria escapes the macrophages, and they do not their PAMs are covered by VI, so the macrophage is unable to kill them. As a consequence, this leads to inflammation, this leads to localized engulfment, and more macrophages are attracted. Once the bacteria is inside the macrophage, it takes over the reproductive function inside the macrophage, and it keeps multiplying inside the macrophage. From there, it is transmitted through the mesenteric lymph nodes to the thoracic duct and to lymphatics, and from there it goes on to all reticuloendothelial tissue of the liver, spleen, bone marrow, and lymph node. There, bacteria multiplies until it reaches a critical mass, leading to apoptosis of the macrophage, and it will then it will then enter into bloodstream and invade rest of the body. Bacteria then infects gallbladder via either bacteremia or direct extension from infected bile. Once it is there, it will then enter the intestine for the second time and may infect the pear patch again or be excreted in the stools. Once it is excreted in the stool, it can then cause infection to others. So this could be illustrated here, that once it is ingested, it survives the it survives high acid tolerance because it survives pH of 1.5. Then it targets the pear patches. After it has been phagocytized, it multiplies. And then there is evasive of immune mechanism because of VI capsular polysaccharide. And from there, it continues to multiply in the from a mesenteric lymph node, it goes to the thoracic lymph nodes, spleens, bone marrow, and liver. And once the macrophage dies, then it enters into the bloodstream and resides in the target organism. It can be gallbladder, it is excreted in the stool. If urine has urine has stones or cystosoma infection, then it can go to the urine also. So the clinical features and physical examination will show that the incubation period is variable. It varies between 7 to 14 days, but in some cases it could be as much as 30 days. The clinical features is gradual onset of fever with one or more abdominal symptoms. On examination, physical examination is usually non-specific. There is soft, tender hepatosplenomegaly, abdominal distension, mild ascites, diffuse or localized tenderness on abdominal examination. There is also bradycardia relative to the level of fever that is there. Normally, for every 1 degree rise in temperature, the pulse rises by 10. In this case, it is lower than that. There may be rose spots on trunk which have blenching erythematous maculopapular lesions. This may be easier to appreciate in whiter persons than the darker ones. If fever progresses beyond the first week, patient becomes impassive and unresponsive. Complications set in the second or third week. If there's delayed diagnosis and institution of appropriate antibiotic therapy is delayed. It can also depend upon bacterial virulence factors and host factors which may contribute to severity of the illness. In 25% of hospitalized patients, there are complications. If fever continues, there's increased weakness, there's anemia, weight loss, persistent vomiting, cloudy mental state, and in about 5%, there may be encephalopathy or GI bleeding. nephritis, and hepatitis. Chronic carrier stage is reached in some places, some persons. Carriers will be asymptomatic but can transmit infection. 10% of acute enteric fever cases continue to shed bacteria intermittently in feces for several weeks. If shedding continues beyond 1 year, then the person is known as chronic carriage state. Then the focus of infection is usually gallbladder. This is common in persons who have gallstones. Normally, it occurs in persons who are fat and over 40 and females. Chronic carriage and gallbladder stones increase the risk of cholecystitis and cancer. Kidney stones as well as Schistosoma hematobium, which is known as urinary blood fluke infections, especially in Egypt, increases risk of chronic urinary carrier state. It has been recommended by public health authorities that food handlers as well as healthcare workers who are diagnosed with typhoid must have 3 stool cultures which are negative for Salmonella typhi. The samples should be collected at least 48 hours apart. Elevated VI antibodies may help identify chronic carrier state in non-endemic region. In the endemic region, because of vaccination, which nowadays includes VI antigen, this may not be useful. The red flag for referral would be in adults when 2 or more of the following, the quick sepsis-related organ failure assessment criteria on initial examination are met. One is altered mental state, respiratory rate more than 22 breaths per minute, systolic blood pressure less than 100 milligrams of mercury. The patient may be at risk of severe sepsis and needs high level of care. In children, you should refer the children to higher level of care of any child who looks sick or toxic, unable to take oral medication. If there's persistent vomiting, signs of severe dehydration, abdominal distension with or without tenderness, jaundice, drowsy or altered consciousness, signs of gastrointestinal bleeding, such as passing fresh blood in stool, signs of hemodynamic shock, including mottled skin and reduced capillary return or seizures. For laboratory investigations, complete blood count should be done. WBCs are usually within normal range. If leukocytosis is observed, it may suggest either intestinal perforation or should suggest alternate diagnosis such as pyogenic infection or leptospira infection. Mild normochromic or hypochromic anemia, thrombocytopenia, and mild elevation of transaminases, liver transaminases with normal bilirubin is common. C-reactive protein is elevated. Blood culture is optimal method for diagnosis and to guide treatment. Bone marrow culture is the gold standard, but rarely performed. Culture of stool, urine, bile aspirate is usually useful for carrier detection and not for acute diagnosis of typhoid. Vidal test is quick, cheap, and simple, but has better negative predictive value than positive predictive value. If we summarize the tests that are available and their advantages, limitations, in blood or bone marrow culture, which is confirmed by positive culture results, the advantage is that this is 100% specific, so it could be the gold standard. And the other advantage is that isolated bacteria can also be used for subsequent antibiotic susceptibility testing and molecular characterization if there's an outbreak. As we know that of late, Salmonella typhi as Salmonella paratyphi A, both have been acquiring resistance, some of them multi-drug resistance, so that antibiotics, the knowledge about antibiotic susceptibility testing is essential before you give adequate treatment. The limitation is that one is bone marrow is painful, bone marrow culture is painful, that's why very few persons do it. Blood culture can be done, but where the disease occurs, those labs do not have the facility. Then when they do submit the sample, it is normally submitted the bacterial load is very low. As a consequence, unless you submit 10 ml of blood, the sensitivity is going to be poor. Blood culture sensitivity is never more than 50%, while bone marrow is 80%. The other disadvantage is that it will take at least 48 hours before you know the results. And unless this has been done early, it's going to be difficult to wait for that long. Larger volume would help in getting the bacteria faster. And if you now use the automated systems, which have resins which will absorb interfering substances as well as antibiotics, and as well as lyse the bacteria, then chances of getting positive results will be more. Bile stool culture, the advantage is that if you isolate from bile or stool, then you would be able to do antibiotic susceptibility testing. And as we'll deal later, that for getting rid of chronic carrier stage, you need to give treatment with the suitable antibiotics for a long time. Bacterial nucleic acid detection, suggested by positive results, is nucleic acid tests up till now have been difficult since not many labs were doing PCR. But now, after COVID, since more than 3,000 labs have been accredited and have ability to do PCR, I would suspect that nucleic acid tests, more and more labs will start doing nucleic acid tests. While PCR, real-time PCR is one option, but as we'll discuss in detail, loop-mediated isothermal amplification, the LAMP test, may be the most optimal method for detection of the bacteria. Up till now, it's been reported as moderate sensitivity and specificity, but it has been suggested that the sample, blood, could be put for culture for some time, and after 1 or 2 rounds of 1 or 2 days, it could be tested by a DNA method, which will then be more sensitive for detection of the bacteria. Finally, what people rely upon is serological methods. The advantage of serological methods is cheap, quick, relatively simple. Many labs can perform this test. It has a quick turnaround time associated with high point of care compatibility. Some serological tests are simple, quick, and inexpensive. The biggest disadvantage is there is anamnestic response. There would be also cross-reactivity, and the sensitivity is moderate and specificity is poor. It's been suggested that it might have more importance in ruling out typhoid than ruling in typhoid. So blood culture could be manual. The only advantage of blood culture manual will be that it is cheaper, and it can be done at any lab. But Otherwise, it takes more time and is not any more sensitive than any other method, and it is very it will use up a lot of resources. On the other hand, automated systems, normally 2 bottles are the best. That is required. At the bottom, they have a sensor where light is reflected off the sensor every 10 to 15 minutes, and as carbon dioxide is produced, then it will change color, and this is recorded on continuous basis, and as the growth index increases, you would know when it is positive. So it is possible to detect positive in a few hours time and make a smear to confirm whether bacteria is present. Every bottle is put into an incubator which has a particular which has a specific a specific lead, which will then detect whether growth is occurring, and it will light up when it is positive. And a smear of this will show you whether it's positive, whether it's gram positive strep pneumoniae or it is gram negative bacilli, and sensitivity test can be put straight away. So in 4 hours time, you have the results. One, the culture is positive. And PCR, it could be regular PCR, it could be real-time PCR, it could also be multiplex PCR, and you could culture the sample for some time and then do PCR. So it will be culture enhanced PCR. The target has been in literature, the target has been CRISPR gene or 16S RNA gene, via B, ST50, FLEC, or multiple genes. One report that I would like to quote is evaluation of nested PCR in diagnosis of typhoid fever by Professor Gopal Nath from BHU, in which he found that using nested PCR, you will get 53 out of 100 cases which are positive. Blood culture was positive only in 17, while Vidal was positive in 41. So nested PCR would help you identify more cases of typhoid. But nested PCR will still take 4 to 5 hours time, and it is normally batch testing. So it takes 24 hours in real time. But loop-mediated isothermal amplification stands for LAMP. It has the advantage that it doesn't need any equipment. It doesn't need any costly equipment because it is done at one temperature. It reduces the chances of contamination. It has low sensitivity to reaction inhibitors, and it'll give you results in 20 minutes time. Here, what is required is that BSM DNA polymerase is used, the DNA sample, as well as specific primers. Normally, two sets or 3 sets of primers are added in one, and then it has been set up. The primer design is very critical, but papers in the literature indicate that people have been able to set up LAMP test for typhoid. And I think now that many labs are able to do PCR, they would be interested in doing LAMP for typhoid fever.
When designing a LAMP experiment, 4 to 6 primers are required, specific to identified regions of target DNA or RNA sequence. Amplification initiates from strand invasion by one of the inner primers, and a strand-displacing DNA polymerase extends the primer and separates the target DNA duplex. The first product is then displaced by synthesis, initiating from an outer primer which anneals to an upstream target region. As it is displaced, the end of the product forms a self-hybridizing loop structure due to inclusion of a reverse complementary sequence in the inner primer sequence. This annealing and displacement cycle repeats on the opposite end of the target sequence, and the resulting product is a short dumbbell structure that forms a seed for exponential lamp amplification. This lamp dumbbell structure contains multiple sites for initiation of synthesis, from the 3' ends of the open loops and annealing sites for both the inner and loop primers. As amplification proceeds from these multiple sites, the products grow and form long concatemers, each with more sites for initiation. The result is a rapid accumulation of double-stranded DNA and amplification byproducts that can be detected by a variety of methods.
The advantage is that it can be done even by naked eye. The detection can be done by naked eye, as you see that accumulation of acidic DNA will lead to change in color of neutral red to yellow, while the negative ones will remain red. Finally, we come to serology. A serology could be agglutination test, which could be tube agglutination, which is known as the Vidal test, and it's more than 100 years old. There is slide test, and I'll tell you about the modified test that we've done when I just passed my MD. Now we have a Tubex test from Sweden, or Typhi from Malaysia, and test IT lateral from the European Union.
That is, typhoid and paratyphoid fever caused by Salmonella typhi and Salmonella paratyphi A and B respectively. Antibodies specific to flagellar antigen H and somatic antigen O of Salmonella species usually become detectable in blood 7 days after the onset of infection in individuals infected with typhoid bacilli. This test facilitates quantitative estimation of antibodies to Salmonella antigens in human serum by slide and tube agglutination test. Principle: when the colored, smooth, attenuated antigen suspensions are mixed and incubated with patient serum, anti-Salmonella antibodies present in the patient's serum react with the antigen suspensions to give agglutination. Agglutination is a positive test result indicating presence of anti-Salmonella antibodies in the patient's serum. Negative test result is indicated by the absence of agglutination. Primary sample: no special preparation of the patient is required prior to sample collection by approved techniques. Collect 2 milliliters of venous blood in a plain red-topped vacutainer. Do not use hemolyzed and turbid samples. Though freshly collected serum is preferable, samples can be stored at 2 to 8 degrees centigrade for up to 72 hours in case of delay in testing. Reagents and consumables: Salmonella typhi O antigen suspension, Salmonella typhi H antigen suspension, Salmonella paratyphi AH antigen suspension, Salmonella paratyphi BH antigen suspension. Polyspecific positive control: glass slide with 6 reaction circles, applicator sticks. Equipment: incubator, timer, 0.1 milliliters and 1 milliliter serological pipettes and droppers, 36 Vidal tubes or Kahn tubes for each sample. Physiological saline, test tube rack. Test procedure: bring reagents and samples to room temperature before testing. Shake and mix antigens well before dispensing. Slide screen method: place 1 drop of positive control onto a reaction circle of the glass slide. Place 50 microliters of physiological saline onto the next reaction circle of the glass slide. Place 1 drop of patient serum to be tested onto each of the required number of reaction circles. Add 1 drop of O antigen suspension to the reaction circles containing positive control and physiological saline. Add 1 drop each of the antigen suspensions, that is O, H, AH, and BH to the reaction circles containing the patient's serum. Mix contents of each circle uniformly over the entire circle with separate mixing sticks. Rock the slide gently back and forth and observe for agglutination macroscopically at 1 minute. Interpretation of results. Observe for agglutination or formation of clumps in the wells. Compare it with the positive control. Agglutination is a positive test result and indicates presence of the corresponding antibody in the patient's serum. Absence of
Professor Rattan, sir. Yes, I would request you all to just stay online. I think we are experiencing some technical difficulty that Professor Rattan sent. Bear with us. He will be back in 2 minutes.
Is that
Yes,
is
sir.
it where we broke off? I'm sorry um, for the disturbance here, but what you require is that if you are going to use the tube agglutination, then you need to use the water bath so that there's convection current which will make the antigen antibody react, and then you have to leave it overnight so that the reaction is complete. Once you once you are ready with viewing the slides, the tubes, then you should use a concave mirror which will give you a better sight. Another one is that normally whenever they demonstrate any doubling dilution, then they take one tube and they keep on taking samples from one tube and diluting and then pushing the next tube, etc., as seen above. But normally it's been suggested that this dilution could be error prone, so you should use the CLSI method for dilution, where you take one unit of the sample and one serum and 1 unit of normal saline, and you get 1:2. Then 1 unit of serum and 3 units of normal saline, and this way you will be able to get doubling dilution. It's also been suggested that to interpret Vidal test, the lab must also share what is the baseline titer in healthy controls. And I have accumulated a few, six of the publications that I could come across from Central India, from China, for Karnataka, Pondicherry, Garhwal, and Klava in UP, which indicate that anything above 80, TO above 80, that means since it's doubling dilution, 160 would be considered as positive, while TH should be about 160 before you can. So if the titer is more than 160, you should then consider that as positive Vidal. Since the agglutination is because of IgM antibodies, and IgM is present in the case of recent infection, while IgG can also cause agglutination, and IgG is normally present from past infection. You can differentiate between these two in fact, that if you repeat the test, maybe the slide agglutination test, with making dilution in 2-mercaptoethanol rather than only normal saline. So 2-mercaptoethanol will destroy IgM, and thereby, if there is fall of titer, then it would mean that this is a recent infection. And I remember when we had done that when I was in Aligarh, from where I did my MD. There we found that in all the 25 culture positive cases, there was more than fourfold fall in titers. So I thought instead of using any of the new machines, new tests, you might want to try this out. Typhi.dot has come from Malaysia, which is based on detection of antibodies to to uh, to a 50 kD protein, which is present in the outer membrane, outer cell membrane of S. typhi. And this test is a lateral flow. It will give you results quicker. Besides this, from Sweden, there's also Tubex, which actually consists of polystyrene beads in which LPS is coated, and then you look at the different colors, that whether there's agglutination or not. But a recent study where they did a meta-analysis said that the sensitivity, which indicates percentage of positives with positive tests who are correctly diagnosed, and specificity, which will give negative results in those who are correctly identified. They said that looking at the sensitivity and specificity from published work, if there were 1,000 fever patients with 30% prevalence of Salmonella typhi, Typhi.dot will miss 56 and give false positive results in 161. Tubex will miss 66 and give false positive in 91. And tested will miss 93 and give false positive results in 70. So overall, they felt that you should stay with Vidal test and you might want to modify Vidal test. There's another paper which was tested with FIND, which is Foundation for Innovative New Diagnosis, based in Geneva, and they said that every country should make its own algorithm. I have been advocating that we should do simultaneously testing, but they have looked at mathematically, they looked at simultaneously testing or sequentially testing. And looking at dengue, leptospira, malaria, scrub typhus, and typhoid, and looking at various prevalence on mathematical ground, that if they look at, if they review 27,000 patients with acute fever, simultaneously testing will give correct diagnosis in 46%. But sequential testing will give you correct diagnosis in 74%. Now, the sequence, according to them, is also very important. So, first point they say is that instead of simultaneously testing, which many of us feel is the way forward, they feel that sequential testing is better results. Then they have mentioned that optimum testing of sequential in India would be, if you have a person with acute fever, you should test first for dengue, second for scrub typhus, and if both are negative, then test for malaria, then test for leptospira, and finally test for typhoid. And this will give you the best, this will give you correct diagnosis in 74%, because you are testing for scrub typhus after getting dengue negative. You're testing for malaria after getting dengue and scrub typhus negative. So, on the other hand, if you use the worst performing algorithm, according to them, by mathematical modeling, is if you test first for typhoid, then you test for leptospira, then you test for malaria, then you test for scrub typhus, then you test for dengue. That'll give you positivity in 51%. So according to them, if you have only limited number of rapid tests available with you, only one test, then test for dengue. If you have two rapid tests, then first use dengue, then to do scrub typhus. If dengue is negative, you'll get positive in 45. If you have three, then after dengue and scrub typhus are negative, test for leptospira. And finally, if all three are negative, then go to malaria. So according to them, this is the mathematical modeling that they've done.
QuickView Salmonella typhi antigen test is an in vitro qualitative immunochromatographic assay for the rapid detection.
So testing can also be done instead of only detecting for antibodies. You can look for antigen, and antigen has been sought in whole blood, serum, plasma, or stool with mixed results. So I think more data needs to be, the sensitivity seems to be 97%, specificity is 98%, but level of detection means 10 to the power 7 to 10 to the power 8 bacteria. That would mean that it is not very sensitive to be used. But I guess more work needs to be done on this. And for cultures, we all know that salmonella will grow better in preferentially. It can be enriched by putting the sample in selenite broth and then using either Salmonella, Shigella agar, where you'll get black colonies, or XLD. And of course, recently, we also have Chrome agar, which can quickly help you identify. Then what you need to do is the sensitivity testing, and you would see that sometimes Salmonella is sensitive to everything, but of course there have been many reports, and since 1990, of Salmonella becoming simultaneously resistant to chloramphenicol, to trimethoprim, and to ampicillin because of a plasmid that was there. So detection, and this has been going on for quite some time. And recently from Pakistan, there were also ceftriaxone resistant outbreaks in Pakistan. Ciproflox is also, in some places, there is resistant. We have analyzed our own data from samples collected from mostly UP and Bihar for Salmonella from blood. You'll notice here that Salmonella typhi as well as Salmonella paratyphi A seem to be sensitive to all the drugs tested in 2019, and the happy situation has persisted and with all the Salmonella, whether Salmonella typhi or paratyphi, except that you notice that Salmonella paratyphi A in 2020 had ampicillin resistant in 50%, but amoxiclav will restore that restores that weakness. So that would mean that Salmonella typhi as well as Salmonella paratyphi A in UP and Bihar can be easily treated by any of the drugs that are required. Though, of course, as they say, the OPD treatment is, if the susceptibility is unknown, then you go for azithromycin at 20 milligram per kg body weight, and for 7 days. The advantage is this has to be given once a day. If susceptibility is known and bacteria is sensitive to everything, then ciprofloxacin is the better choice. But if you want a
Sir, your voice's audio has stopped.
hello,
Yes, sir. We're back, sir.
okay. It says my connection is unstable.
Ah,
Though I have only a few slides to show now. So this is to say that in case of severe infection, there would be you would then want to use injectable ceftriaxone or even meropenem. And eradication of chronic carriage depends upon susceptibility of the isolate. Along with susceptibility of the isolate, you have to give treatment for 90 days in some of the cases. And except if you have ciproflox sensitivity, then ciproflox in 28 days will get rid of Salmonella typhi from the gallbladder. Sometimes you have to get the gallbladder removed. There are 3 vaccines available, and all of them are effective. The best effective is made from Bharat Biotech, which is typhoid conjugate vaccine, where 1 dose needs to be given, and this needs to be given to anybody above 6 years of age to 45 years of age, and it gives high titer and give protection for 5 years. So I would strongly advise that all of us should go in for typhoid conjugate vaccination, and that will then protect us from typhoid fever. And this has been recommended not only by the Indian Academy of Pediatrics, but also by Center for Disease Control, CDC, as well as WHO. There's also differential diagnosis, because the fever without any localizing sign, it has been suggested could be because of malaria, could be dengue, could be scrub typhus, could be leptospira, or could be chikungunya, or could be typhoid. So in this,
Fast Track Diagnostics, syndromic real-time PCR, multiplexing that serves the clinical need. Let's see why this is important to you.
Imagine a scenario where a person falls ill. They go to the doctor for a diagnosis. The doctor is concerned about the patient's symptoms and overall presentation and decides that further investigation is required. A sample is taken, for example a blood sample, and a test is ordered from the lab based on what the doctor expects to be the most likely pathogen causing the illness. The test takes place, and the results come back negative. A second test must then be ordered. It also comes back negative. A third test is ordered, and the cycle repeats until a positive result is found. Time ticks by. This repeated testing is bad for the patient, frustrating, wastes time, reagents, and money, and the patient remains untreated as he waits for a diagnosis, possibly getting sicker. Worse yet, the patient could be prescribed unnecessary medication, like antibiotics for a viral illness, before the test results are confirmed.
Now imagine the same scenario, but the doctor can order a test from the lab for all probable pathogenic causes, viruses, bacteria, fungi, or parasite, at the same time using one test. This is syndromic real-time PCR multiplexing. Yes, it saves time, resources, reagents, and money. But most importantly, it is better for the patient because it is an effective aid to fast clinical diagnosis, reducing morbidity and the risk of mortality, particularly in cases involving immunocompromised patients. Wouldn't that be better?
At Fast Track Diagnostics, we manufacture the largest range of syndromically grouped.
The syndromic approach means that you test for dengue, for scrub typhus, for salmonella, for plasmodium, for chikungunya, for leptospira simultaneously. And with one sample, by the end of the day, you have the results. Now, one of the reasons why eradication of typhoid fever has been very difficult is because typhoid is restricted only to human beings. There's no animal which is susceptible. What is required then is that each one of us should be vaccinated. We hope that the environment would improve, and we hope that we would not misuse the antibiotics. So taking care of environment, making sure that we have safe disposal of feces, we have clean drinking water, and we have vaccination would help overcome this problem. I thank you for your attention.
Thank you very much, sir. Sir, could you have your video on, sir? Right. Sir, just a quick, we have a couple of questions. That was very enlightening. Typhoid being one of the older diseases, it's not one of it's not the 20th century disease. It's been there since the time of typhoid Mary, as you said. So this vaccination, sir, how effective is this, in your opinion? How effective is this vaccination in terms of how long are we immune, to typhoid after getting this vaccination?
5 years is what they've tried to indicate, that if we take the vaccine, especially the conjugate one, then a 5 years protection has been observed in Nepal and in other places. VI vaccine is, see, there's an oral vaccine which is not as effective as the VI vaccine, but the conjugate vaccine is even more effective. So about 80% of protection and for 5 years.
That's a reasonably long time, I would assume.
Yes.
Because more.
So all visitors, it will be best if visitors, before they come to India or this side, they take the vaccination, and all the residents also take the vaccination.
In fact, sir, part of this COVID pandemic, one observation that came across, I was talking to some of the medical practitioners last year. They said, Arjun, the incidence of typhoid has come down because everybody has started washing their hands. Everybody has practiced better cleanliness, better hygiene, and it has made a difference. It has actually made a difference because even at the lowest of the lower economic strata, people had been careful about in the beginning of using, the sanitizers and being a little careful with their hygiene, especially.
Yeah.
I think that is it had a direct correlation with the incidence of typhoid. And so we have this time, in fact, we have a lot of questions. A lot of people have come up with interesting questions. You know, so there was a question from a gentleman who said, "Sir, I read somewhere about if there is such a thing as minimum time period of blood culture comes positive, as this may be false positive. Another one is time between two blood culture samples, left and right hand, they come positive." Now, I couldn't, I'm sure you will make a little more head and sense of this particular query.
See, those are mostly for septicemia. Of course, this is also a septicemia. And if you want to give blood culture, then the best is that two samples are put. What happens with single blood culture is that if there's a skin contaminant, one is, of course, you're looking for pure culture. You expect that the bacteria, there'll be only one bacteria which will be isolated. But that can come, even staph epidermidis, which is in the skin, can come. And then we're not sure whether it is from the skin or it's from the blood. So if two samples, one, of course, would be to clean the skin very well, and make sure that that it is dry, then you puncture it. The second one is if two samples are given, if both grow the same organism, then you're sure that this is the pathogen that you're dealing with and not with a contaminant. So that's why two bottles in any good place where they use blood culture and automated blood culture, then it's worth the cost involved in using two bottles rather than one bottle.
So another question that came to mind was, you talked about vaccination and how we shouldn't be overly dependent on antibiotics. But, the vaccination is a recent development. So how has this drug resistance been affected? People have become more drug resistant as time has gone by. So how has that affected the treatment of enteric fever, sir, typhoid, sir?
See, the bacteria, what happens is that the bacteria has to pay a price for carrying drug resistance. Salmonella, this is in case of salmonella. So salmonella, whenever possible, it tries to get rid of the resistance mechanism. So in 1990, it was still sensitive to chlorphenicol, to ampicillin, to trimethoprim. Then suddenly it gained a plasmid, which gave it resistant to everything. So it became simultaneously resistant to all the three drugs which are commonly used. At that time, in vitro sensitivity to aminoglycosides was noticed, but aminoglycosides do not enter into the cell, so that in vivo there was no efficacy. And luckily at that time, ciproflox became available. But ciproflox had a warning that it affects the weight-bearing cartilages in beagle dogs. So it could not be given to children. And at that time, there was the dilemma that pediatricians faced, that whether if you don't give them any effective treatment, the child will die. If you give them ciproflox, then the child might get crippled. Finally, they said, let's give ciproflox, and the patient responded very quickly. Then they followed up the children who had got ciproflox, and they found that the weight-bearing joint damage that was seen in beagle dog does not translate into human beings. So that there's been subsequently, now of course we know that fluoroquinolones can increase the QT interval, can cause tachycardia, can affect the Achilles tendons. So there are many infirmities in fluoroquinolones. But one of the good things was that at that time it saved many children, and for many years it's been used very well against Salmonella typhi. And Salmonella typhi was so sensitive that instead of using Salmonella typhi was so sensitive to ciproflox that instead of ciproflox for in vitro testing, you would use nalidixic acid as a surrogate marker, because nalidixic acid was 100 times less sensitive, less effective than ciproflox. Ciproflox was very effective. Subsequently, in 2012, they changed the definition of breakpoints, and then they found that many Salmonella paratyphi A started becoming resistant. But as I showed you our results for 2019 and 2020, both Salmonella typhi and Salmonella paratyphi A are sensitive to all the drugs that we have tested. So it keeps varying, it keeps acquiring, but it wants to, unlike say Pseudomonas or E. coli or Klebsiella, it likes to lose the sensitivity. Okay. And that's why in many regions, Salmonella is still sensitive to all the drugs.
So a follow-up question to that would be, sir, in the current time, which antibiotic is most effective against Salmonella SPP, including typhi, paratyphi, and other sarobas?
As I indicate, see, we must be focused on one is if it is non-salmonella, non-typhoidal salmonella, no antibiotics need to be given. That will only cause loose motions. In typhoid, the drug of choice at this moment is either azithromycin or ciproflox as an OPD measure. And if you admit the patient, then you can give third generation cephalosporin or meropenem.
Under the right medical supervision, I'm sure.
Yeah.
So, sir, when we come to, again, another question regarding cross-reactivity, coming to the diagnosis end of it, there was a question where they said, if there is any cross-reactivity occurring typhi dot when, or a typhoid rapid test when a person is positive for dengue. So you gave us a sequence, the sequential testing system that you start with dengue and then you move down the line till typhoid is at the end of that spectrum, number 5 in that particular line. So any reason why that particular spectrum has been devised?
This is mathematical modeling, and on that they felt that depending upon the sensitivity and the specificity of the rapid tests, if it is in this sequence, you are more likely to pick up the right pathogens. Though I still could not understand myself that if you do everything simultaneously.
Yes, what would be the big difference in that, right? Because
I did write to the author saying that this is mathematical modeling. See,
fair point.
It is not, but somehow it defies logic that if you test all 5 of them together, if I have the money and the resources, if I do all 5 together, I should pick up whatever is there rather than doing sequentially. Because the advantage of simultaneously is that in one round, with one sample, you will get all the results. While if you do sequentially, then it will take the whole day for you to answer on one
patient. So to get one patient right, and therein also you're doing the process. You're following a process of elimination. That's how.
This is the publication in Clinical Infectious Disease by FIND. And I
respect the publication. I just the logic has still it escapes me a little bit, to be honest with you. Sir, there was another question about if you have, is it possible that in a typhoid rapid card, the result is negative, but in slide Vidal, the results are positive. Is that a...
Yes, they are, see, ultimately, as I said, um, the rapid tests are not any better than typhoid. So it is up to you, whichever, what you need is assurance. First is your clinical judgment. In many cases, you can make a clinical judgment. You should do the diagnosis by culture if possible. If you don't want to do culture, then any of the rapid tests could be there, and every possibility is there that one is positive and the other one is negative, because they're looking at different parts of the organism, and it has more negative predictive value than positive predictive value. And there is one is cross reaction and the other one is anamnestic reaction. Anamnestic reaction means that in the past you have suffered from something and now it is memory. It's the body is remembering that old injury and reacting to the present one.
Yes, we call in workout terms we call it muscle memory, or here it call it a similar term.
Anamnestic response. Yes.
So acid-fast bacilli, UTI, and show a false positive slide test. How are we supposed to differentiate on that? I don't know if that's relevant to this particular topic, but it's a question that came up. So I'm
acid fast, as they say, urine should not have the acid fast test done, because urine has Mycobacterium smegmatis as a commensal. So if you get and get acid fast, if you do acid fast smear of a urine sample, then you might get false positive, and it will cause more anxiety than solve the problem, because there's a commensal which is present in the smegma. So it is better if you want to think, if you feel that the person is symptomatic, then it's better to do Gene Expert Ultra along with culture. For TB diagnosis, that should be clear.
I think this is another question that's come up. How to set the cutoff titer for the Vidal test?
Cutoff titer of the Vidal test that I showed you, 6 of them have looked at healthy individuals who have donated blood and then done Vidal test on them. And they find that means persons who are healthy, who are not infectious, who are not having fever. If their titer is done, then O titer will be 1:80, H will be 1:80 or 1:60, 160. So that would mean that if you have current infection, the titers must be at least 2 times or 4 times more.
All right. Nowadays we use, or the doctor prescribes, broad spectrum antibiotics. Is it possible that it can lead to false negative results or have any effect on the IgM titer going forward, sir?
See, if the antibiotics that has activity against salmonella, then it'll treat some of the salmonella. It may not completely cure it. So if the bacterial load is decreased, then the antibody response will also be decreased. So it can interfere with the diagnosis.
There is another question about treatment of recurrent salmonella. I think typhoid Mary suffered from recurrent salmonella because obviously couldn't cure her.
So what normally happens is that that the gallbladder is the normal site of infection, and gallbladder normally would be site of infection, especially if there's a stone. So the person must be investigated for stone, and if the foreign body is there, then you're not going to be able to sterilize it. And since there's risk of cholecystitis as well as cancer, it may be wise to remove the gallbladder.
I think that's a long-term solution for this one. What would be the effect of rapid on rapid testing in case of typhoid carriers, sir? Would there always I mean,
Carriers, there the antibody titer is not too high, but what you're looking for is bacteria to be present. So what you will do is either look at bacteria in the stool or in the bile duct, bile aspirate. There was a time when we used to depend upon VI antibodies, because if VI antibodies are raised, that would mean that the person is carrier. But if a person has taken vaccination, then it may not be valid, because vaccination now consists of VI antigen.
okay, so you're
So
solving that
antibodies
problem.
will be raised.
Sir, I think we have time for one last question. This has been an interesting question answer session. It's people have been curious today. As per CLSI, now MIC is required for SIP locks. Is that the
They've
question?
changed the breakpoint. See, initially the breakpoint used to be one microgram per ml would be the breakpoint. Then they found that instead of one breakpoint, 1 microgram, they should use 0.06. So then you have to do MIC, because only 0.06 seem to be able to reach at that level. So, and that is what UCAST has also indicated. Both CLSI and UCAST in 2012, they had recommended that this should be the breakpoint. For that, naturally, you have to do culture. You have to do culture and do MIC.
Right, sir. This has been a long session, sir. Thank you so much for your time. I'm sure our questions can keep coming, and we will. Let everyone know that in case you have any questions, please feel free to write into us. I will share the questions with Dr. Rattan and our technical team and endeavor to answer them to the best of our abilities. Sir, as is our practice, please allow me to share a digital version of our certificate for now. Right?
Thank you.
And wish you a very, very happy Diwali, sir. I will drop in and take up some of your time after Diwali, right?
Sure.
So thank you very much for your time, sir. Thank you everyone for attending this presentation scientific lecture on enteric fever diagnosis, challenges, and future directions. Thank you everyone. Have a good day.
Thank you.